Thanks, guys, for coming today. We really appreciate this program is expanded greatly, especially this neuro workshop that we're having. It's like doubled or tripled in size since last year. So it's only the second year that we've done it. We really appreciate your attendance. Thank you. So as Winnie said, I'm a nurse practitioner in the neuro ICU. I love my job. It's one of the best jobs I've ever held. So hopefully I'll continue there for many more years. My talk today is blood pressure management in acute neurological conditions. I'm going to have to do two things, run this and run that. So forgive me if I'm a little slow here. Forward. There we go. So my objectives today are to define appropriate blood pressure parameters according to the guidelines for each neurological condition that I cover, summarize why we use each particular blood pressure and that we utilize for each neurological condition, and apply the knowledge. I want you guys to be able to apply that knowledge that you obtain here in this lecture in your everyday practice. I have no disclosures at all. First, we'll start off basic. What is blood pressure? Blood pressure is the force of the blood against the walls of your arteries as it circulates through your body by your heart. And without a blood pressure, your body wouldn't be able to get the oxygen that it needs to survive. And blood pressure is extremely important when we're discussing neurological injuries because the brain needs oxygen too, just like any other organ in your body. And your blood pressure needs to be regulated because too high a blood pressure can cause hemorrhage and too low a blood pressure can cause ischemia, which can lead to infarction. So a few important facts. As somebody said earlier, approximately 1.9 million neurons die each minute. But how do we know that our brain's getting enough perfusion and enough oxygen? So there's a calculation called the cerebral perfusion pressure. And we use this every day in the ICU for patients that have EVDs in. And it's the net pressure of blood flow through the brain. So a CPP is regulated by two balancing opposing factors, one being your mean arterial pressure, which is a force of the blood that's trying to get into your brain, and then your intracranial pressure, that is the force keeping it out. So a normal CPP is 70 to 90 in most adults. Sometimes we'll drop it down to 65. But in order to calculate our CPP, we have to know how to calculate our mean arterial pressure. Being in the ICU and most hospitals, monitors now actually give you the mean arterial pressure, but it's good to know just the calculation. It's your systolic plus 2 times your diastolic divided by 3. There we go. So some of the neurological conditions that I'm going to cover are ischemic stroke, intracranial hemorrhage, subarachnoid hemorrhage, posterior reversible encephalopathy, and spinal cord injuries. So first we'll start off with ischemic stroke. Here's like a list of, our definition of ischemic stroke. I know you all know what ischemic strokes are. Just so you know, that can be caused by cerebral thrombus, which is the development of like fatty plaque within the vessel. And it also can be from a cerebral embolism that actually comes from the heart. A piece breaks off and it goes throughout the brain circulation and ends until it can't pass anymore through the vessel. So that's the usual cause for that is atrial fibrillation. So annual incidence of stroke is 780,000. The calculation's it's probably a little bit higher now. And stroke is the 5th leading cause of death in the United States. Acute ischemic stroke is the leading cause of disability, medical expenditure, and ICU admissions nationwide. So there's 3 types of ischemic stroke patients that I want to discuss. One is our medical managed patient, where we don't do any type of therapy, IV TPA or thrombectomy on. IV TPA only patient, an endovascular therapy patient with or without TPA. Oh, I missed that. Sorry. Got to do both. So first, our medical management patient. Recommendations are to allow permissive hypertension for these patients. We're going to allow their blood pressure to go up as high as it needs to, unless it's above 220 or 120, we're not going to touch their blood pressure. This blood pressure should not be treated, like I just said, unless they're above those parameters or these patients have other acute problems. If the blood pressure is indicated to be treated, we need to proceed cautiously by only lowering that blood pressure by 15% in the first 24 hours. The blood pressure, this higher blood pressure is an attempt to continue to perfuse the brain and prevent any further ischemia or infarct. But keep in mind, when we're lowering that blood pressure, any lower blood pressure can worsen that ischemia. These patients also need to be monitored for hemicraniectomies, and that's where you remove the skull and let them swell outward, so that will help with that brain compression. These parameters have not been changed in the guidelines for many, many years, as described earlier by Kiffin. Next patient is our IV-TPA only patient. The recommendations are there was randomized clinical control trials for IV-TPA, and the systolic blood pressure that they used for those trials were less than 185 and a diastolic of less than 110 before treatment, and then 185 over 105 for the first 24 hours. And those actually are our American Heart Association guidelines. So those are what we follow today. There were also multiple studies to suggest that there is a higher risk of hemorrhage after IV-TPA if the blood pressures are elevated above those. That exact blood pressure is unknown, though. So there are many research studies relating to TPA. However, one that applies here today is the post-TPA blood pressure elevation and its association with hemorrhagic transformation. This was a randomized controlled trial of TPA versus a placebo in ischemic stroke patients. They hypothesized that the acute size of the stroke, like the initial stroke size, would be larger and the blood pressure would be higher in the patients that converted to hemorrhagic transformation. So they assessed 97 patients over a period of 2 to 5 days after the infusion. So when they examined the results of this, the parenchymal hematoma was more frequent in the TPA patients as opposed to the placebo patients, 11 in the TPA and 4 in the placebo patients. They also found that the parenchymal hematomas in those patients that had the hemorrhagic transformation, that the size of the stroke initially was larger in those patients as opposed to the patients who got the placebo. So as Kiffin explained earlier, that size of the stroke will cause hemorrhagic transformation or is a risk factor. So given this large strokes, we try to avoid giving TPA. And the study concluded, I did want to tell you that the baseline blood pressures in both of these groups were exactly the same. There was no difference. However, throughout the 24-hour period, the TPA patients that had this hemorrhagic transformation, their blood pressure was 18 points higher than the placebo group. So the study concluded saying the size of the stroke as well as blood pressure was a factor in their hemorrhagic transformation. Trying to do both. Okay, next is our endovascular thrombectomy patients with or without IV-TPA. And the IV-TPA, if it was administered to these patients, the guidelines state that it's reasonable to maintain a blood pressure less than or equal to 105 or 180 over 105 during the first 24 hours period after the procedure. Those who undergo a successful reperfusion, it is reasonable to maintain that blood pressure at a level of less than 180 over 105. If no IV-TPA has been administered, the optimal blood pressure management is variable, and it depends on patient factors, the degree of reperfusion, the TICI score. The higher the TICI score, the higher reperfusion. So if it's a TICI score 3, they have complete reperfusion of that area of the brain. And also the interventionalist input. They are the ones that are in doing the angio. They can see how much stenosis or athero the patient actually has to see if they need to require a little bit higher blood pressure. So practice vary between normal tensive goals a 20% reduction from their blood pressure at admission, and also permissive hypertension. So patients that can't be reperfused at all, they can't get that clot out, we're definitely going to have a higher blood pressure in those patients in order to try to perfuse that area, just like as if we did nothing to the patient initially. So there's very limited data out there right now to guide the blood pressure management in our post-thrombectomy patients, yet I say, I'm sure there's studies coming down the line to look at the blood pressure management of those patients. So no standards yet. I did speak with Dr. Nima. He says he likes to keep his blood pressures less than 140 in these patients. So I'm sure other factors are included in that. So there are 2 studies, trials in regards to thrombectomies. They didn't actually look at the blood pressure management in thrombectomies. However, they did examine thrombectomies and timeframes and other things. The ESCAPE trial used the blood pressure greater and equal to 150. And it's probably useful in promoting and keeping collateral flow adequate to the arteries that remain occluded. So that's one study that had a blood pressure parameter within it in regards to thrombectomies. And also the Dawn trial that was talked about earlier, its protocol recommended a blood pressure less than 140. So those are things to, maybe they'll use a couple of those blood pressures when they're starting to look at the blood pressure management post-thrombectomy. So, sorry, forgot to move the slide again. Next is our hemorrhagic stroke patients. And you all know what a hemorrhage is. It's blood spilling into the brain. The incidence is 25 out of 100,000 per year. It's the second most common stroke, and it's more frequent in African Americans, Asians, men, and people over the age of 55. So through my research that I did, and I got several studies sent to me and a few PowerPoints sent to me. One of the main goals in treating hemorrhagic stroke is to prevent expansion of that stroke further and prevent further neurological damage. So when I looked at all this information that was sent to me, early hematoma growth occurs in 30% of ICH patients within the first 3 hours of onset. And that causes significant deterioration in these patients. Increased 30-day mortality with admissions MAPS greater than 145, and this is attributable to the higher risk of hemorrhagic expansion during the first 3 to 4 hours. And also even 1 cc larger of a stroke has the likelihood of a 7% increase in worse clinical outcomes. So avoiding that hemorrhagic transformation is key in these patients. So studies have conflicted over whether elevated blood pressures predispose patients to hematoma expansion after ICH. There's several recent studies that have went on that studied the efficacy and the safety of aggressive blood pressure lowering in acute ICHs. One was the INTERACT-2 trial. Patients were treated if their blood pressures were between 150 and 220, and they were treated initially within the first 6 hours of onset. It compared the aggressive blood pressure group, less than 140 group, compared to less than 180 group. Their GCSs need to be 6 to 15, and the goal of this study was to get that blood pressure down to less than 140 within 1 hour of being randomized, and they had to maintain that blood pressure for 7 days in this study. So the medications that were used were ACE inhibitors, diuretics, topical nitrates, and the outcome that was measured after this study, the primary was the modified Rankin scale of 3 to 6 at 90 days. So I'm not going to go over the secondary ones here. Guys, I keep forgetting to move this thing. Jeez. Okay, so the results of the INTERACT-2 study. There was no significant difference in the primary endpoint of death and disability. There was the modified Rankin score 3 to 6. In the intensive blood pressure group, the less than 140 group, there was 52% compared to 55.6% in the standard group. That's where those blood pressures are the modified Rankins scored. So there also was a trend of improvement, functional outcomes within the less than 140 as compared to the less than 180 group. The mortality was similar in both, and the hematoma expansion was just a little bit more, 1.4 cc's more in the higher blood pressure group, the less 180. So what was the results or the response to this INTERACT-2? The American Heart Association changed their guidelines for hemorrhagic stroke that systolic blood pressure less than 140 is safe and can be potentially effective in improving functional outcomes in patients similar to those that were enrolled in this study. Then came along another study called the ATTACH-2 trial. This is with an antihypertensive treatment of acute cerebral hemorrhage study. These patients were randomized in 4.5 hours to 2 targets. The first blood pressure group was 110 to 139, and the second group was 140 to 179. Let me turn the slide so you guys can see what I'm talking about. The GCS had to be between 6 and 15. The ICH had to be less than 60 cc's, and the blood pressure had to start within 3 to 4.5 hours of the time of onset. And the study group, the less than 140 blood pressure had to be within 2 hours, and it had to be only maintained for 24 hours in this group. So the medications used during this trial was nicardipine, followed by labetalol, as well as diltiazem, uropidol, and its outcomes that were measured, the primary outcome was a modified Rankin of 4 to 6. And its secondaries were pretty similar to the previous study as well. So when looking at these results of the ATTACH-2 trial, the modified Rankin was in the intensive group where they lowered the blood pressure down, the 100 to 139 was 38.7, compared to the higher blood pressure group was 37.7. So there was hardly any significant difference in those two. And so they looked at the modified Rankin of 3 to 6, similar setting, no difference. So they're saying in the ATTACH-2 trial, there's no difference in the blood pressure groups, less than 140 or less than 180. Oh, Jesus. Okay. Okay, so no significant difference, I'm on the same one here, when using the ordinal analysis based in the Rankin shift. The mortality was similar in both groups, but the hematoma expansion greater than 33% was just a little bit higher in the ones that we allowed to go up to 180. So 24% in the standard blood pressure group as opposed to 18.9 in the intensive blood pressure group. So, however, when you're lowering somebody's blood pressure down, there's a possibility to have renal adverse events. And that's what they found in this study, that when you apply a more aggressive blood pressure management to try to achieve hemostasis, then it can potentially impact the kidneys or impact the renal perfusion and hurt the kidneys. So the rate of renal adverse events at 7 days after these patients were randomized were significantly higher in the lower blood pressure group. So it was a 9% in the lower blood pressure group as opposed to 4% in the standard blood pressure group. So current guidelines are, as we said earlier, the American Heart still has that blood pressure goal of less than 140. Patient, these are current guidelines. Patient, as Kiffin said earlier, hopefully they match up with what she has said. Blood pressures patients presenting with 150 to 200 blood pressure, lowering those patients to 140 is safe and may be effective in functional outcome. But when patients come in with blood pressures greater than 220, there's not really any target. It's less clear on what to do for these patients, but adding antihypertensive IV medications is acceptable and is reasonable for these patients. However, the Neurocritical Care Society just recently came out with new guidelines that they haven't been adapted yet by the American Heart Association. And this was after the ATTACH-2 trial finished, that they're recommending a less than 180 for hemorrhagic strokes. Sure, there's other components that are involved in that, but that's what I have right now. So the American Heart has not updated their guidelines yet for this. So next, the topic is subarachnoid hemorrhage. I'm not going to go over a whole lot on this slide. Jeez, Louise, just keep telling me. You'll press it? Yay. So we all know what subarachnoid hemorrhage is. 80% of them are spontaneous, non-traumatic, and result from aneurysm rupture. There's other causes for aneurysms or for subarachnoid hemorrhage that are non-aneurysmal, like in perimesencephalic subarachnoid hemorrhage, which is venous trauma, dissections, vascular malformations, and vasculitis. There's 30,000 people affected every year from subarachnoid hemorrhage, and there's a higher incidence of 2 to 1 in women than men. African Americans, Hispanics, and people over the age of 55. Don't really want to get to 55 yet. So, current guidelines. Did you do it? Yay, okay. Current guidelines are to maintain a systolic blood pressure less than 140, and this is typical prior to securing this aneurysm. We don't want any rebleeding with these patients. So once the patient's aneurysm is secured, whether it be most likely from coiling, our goal is to maintain good cerebral perfusion, and our blood pressure goals are going to change. We're going to liberalize those goals on those patients. Now, if the patient is indeed in vasospasm, blood pressure goals change again. We're going to be permissive hypertension with those patients. We're going to allow those blood pressure up to 160 over 220 or 180 over 220. And it's actually up to your neurointensivist where to keep these blood pressures. And how we get those blood pressures up that high is we could use vasopressors, blood transfusions, IV boluses, things like that. According to the Neurocritical Care Society, 70% of patients experience some clinical improvement with these elevated blood pressures. So, and the goal that they had was like 160 to 180. So these patients, the vasospasm improves and the neurological exam improves. So, and again, avoiding hypotension in these patients is key. It helps prevent any kind of secondary injury. Next. Yes, okay. So now to make things a little bit more confusing. So if you have a low-grade Hunt and Hess score, we all know the Hunt and Hess score is an aneurysm subarachnoid hemorrhage grading. I don't know if you guys can see it down there at the bottom. 1 is your very low risk patient. They maybe have just a small headache. They're not confused. They have no weakness, anything like that, just a little headache. So the higher grades are your more severe, unconscious, comatose, things like that. So if you have a low-grade Hunt and Hess score, you're going to keep that blood pressure less than 140 because there's less chance that patient's going to have a real high ICP. So, and then patients that have a higher grade subarachnoid hemorrhage and that are sleepier, you're more concerned about the patient's ICP. So you want to set those blood pressure parameters just a little bit higher. So I have 3 patients here. Yes. So first one's a Hunt and Hess of 1. So you're very low subarachnoid hemorrhage. You've got a systolic blood pressure goal of less than 140. So how we calculated things earlier, your blood pressure is 170 or 125 over 70, which makes your MAP 88. If their ICP is only 5, it makes their CPP 83. So you MAP minus your ICP. So if you use that same blood pressure goal for a patient that has a Hunt and Hess score 4, you can see here it makes their CPP 68, which is less than what is recommended. So if we raise that blood pressure goal on that Hunt and Hess patient raise it up to less than 160, their blood pressure is 150 over 90, their MAP is 110, if their ICP is 20, we're still within goal with a CPP of 90. So we play with that a lot in our ICU, where to keep blood pressure parameters and goals just so we can maintain that cerebral perfusion. So there was rebleeding is a major concern of subarachnoid hemorrhage. So there was occurs in about 4% of patients within the first 24 hours, 8% within 72 hours, and 20% within the first 2 weeks if they're unsecured. If you're securing, it's much different. So the risk highest, of course, being on that first day that they bleed. So evidence suggests that early repair and vascular treatment of these patients helps reduce that likelihood of rebleeding. Other evidence has found a statistical significance in the correlation of blood pressures less than 160 as a risk factor, or greater than 160 as a risk factor for rebleeding patients with unsecured aneurysms. So follow your orders, make sure everything's perfect with your patients in regards to blood pressure on these patients. So our next topic is posterior reversible encephalopathy syndrome, or PRES. It's a syndrome of acute onset neurological symptoms due to reversible subcortical vasogenic edema. And this occurs secondary to the inability of that posterior circulation to auto-regulate in response to changes acutely in your blood pressure. So I don't know if, the CT scan there, it's a CT without contrast. The bilateral posterior hypodensities is consistent with a patient with PRES. The diagnosis is typically made clinically with an MRI of the brain often, and it reveals hyperintensity of the T2 weighted imaging there on this would be on the right for you guys. So 5 etiologies for PRES. It's divided into 5 categories. Severe hypertension, 61%. People taking immunosuppressive medications can cause PRES. Eclampsia, lupus, kidney failure, postpartum hemorrhaging. And all these patients are altered because of their hypertension. So the treatment for PRES, you're going to eliminate the inciting factor, take away what's causing this posterior reversible encephalopathy. So studies suggest that decreasing your systolic blood pressure by 15 to 20% in the first 6 hours is what's recommended. Hypertonic saline, supportive care, anti-epileptics may be warranted. Many cases resolve within 1 to 2 weeks after controlling the blood pressure and eliminating that inciting factor. Some cases may persist to cause permanent damage in the form of visual changes or seizures. Though uncommon, I haven't seen in our ICU yet anybody pass away from PRES, but it can cause progressive cerebral edema, compression of the brainstem. They can actually have intracranial pressure as well as intracerebral hemorrhages from this. Okay, next is spinal cord injuries. So approximately 10,000 patients per year suffer from spinal cord injuries. 200,000 patients currently reside in the United States, either paraplegic or quadriplegic. It's male predominance, 4 to 1, and the median age is 37 years old. And its etiology is listed there, 39% from motor vehicle accidents. Even though we don't care for a whole lot of patients with spinal cord injuries at Baptist, but it's just good to know some of this information. So spinal cord injuries also require perfusion, not necessarily just to the brain, but also the spinal cord. So the data is controversial. There's not really any set parameters out there right now in regards to spinal cord injuries. One of the many complications to acute spinal cord injury is neurogenic shock, bradycardia, and hypotension. And this is secondary to a sympathetic failure associated with that cervical and high thoracic cord injury. We manage bradycardia with enteral albuterol. IV beta agonists, scopolamine, atropine, and even possibly pacing. Our last spinal cord patient we ended up having to get her paced. Treatment for the blood pressure is IV crystalloids, blood transfusions, vasogenic meds or vasoactive meds, and just to maintain a normal tensive in that patient. So across institutions, there are protocol. Most of them are using a protocol to keep their mean arterial pressure greater than 85 to eliminate any kind of secondary ischemic cord injury. So pharmacology, for the lack of time, I'm going to go over just the labetalol, hydralazine, nicardipine, and Clubax, medications that we use to bring the blood pressure down. So labetalol, it's a third generation selective alpha-1 agonist and a non-selective beta adrenergic antagonist. It has vasodilatory and antihypertensive properties. It's less likely to dilate the cerebral vasculature. It's given in an IV bolus. As you all know, it's 10 to 20 milligrams over 2 minutes. We can also give it as a drip, 2 milligrams every minute, and titrate up by 1 milligram every 10 minutes to a max dose of 5 milligrams a minute. And its side effects are scalp tingling, dizziness, nausea, vomiting, and bronchospasms. So we need to be very cautious when we're giving this to CHF patients as well as COPD patients because it can cause bronchial constrictions. Hydralazine is another medication. This is a peripheral artery vasodilator. It causes relaxation of the blood vessels, which is carrying blood away from the heart and towards all of our organs and tissues. So it affects the calcium movement within our vessel. Calcium is what causes our muscle contraction. And therefore, when we use hydralazine, it disturbs that movement of calcium and causes that smooth muscle just to relax. So we can give 5 to 10 milligram every 4 to 6 hours. Can cause headaches, nausea and vomiting, loss of appetite, diarrhea, and a fast heart rate and chest pain. We like to use this medication if our patients have a lower heart rate because this does not affect their heart rate. Nicardipine, we use this, I think every patient's room has this running. It's a calcium channel blocker. It inhibits the calcium influx into the vascular smooth muscle, the myocardium. It produces like a peripheral and coronary vasodilatation. We start at 5 milligrams an hour, and we increase by 2.5 milligrams every 5 to 15 minutes to the desired blood pressure. Its max dose is 15 milligrams an hour, and we use the minimal amount of medication to achieve the blood pressure goal. Last drug is Clubax. It also is a calcium channel blocker. We start the infusion at 1 to 2 milligrams an hour. You double your rate every 90 seconds until you're close to your blood pressure goal. And then you increase in smaller increments every 5 to 10 minutes until you achieve the blood pressure that you want. Its max dose is 32 milligrams an hour. Its advantages, it's less volume than what nicardipine is. So some of our CHF patients, we like to use a lower volume in these patients. And also it is has a larger therapeutic window. Its half-life is only 1 minute. Contraindications is hypertriglyceridemia. It can cause severe aortic stenosis, it's contraindicated in patients with aortic stenosis, and soy and eggs. So administration keys to this is it's lipid-based, so you have to change that tubing just like you do on propofol every 12 hours. And these patients have to have triglycerides monitored daily just to make sure they're not rising and off the wall. So I'm finished. Take-home points of this lecture would be to know your blood pressure parameters, know your orders, know why your blood pressure parameters are where they're at. And if you don't, just ask somebody, why are we 140 instead of yesterday we were 180? So use the least amount of medication, IV medication to achieve the goal that you want, the goal blood pressure, and avoid hypotension because it's equally as important as hypertension. And anticipate what medications you're going to need at the bedside. If you have things ordered PRN, get them up, get them on the unit, anticipate having to use those medications. And here are my references. Do we have any questions? Thank you.